Okay, so we'll go ahead and get started. As you all know, we're in the rare bleeding disorder breakout group. My name is Gianna, and Dr. Chitler is a mentor of mine and helped me work on this presentation. So as we go through, this is just a little bit about both of us. And so here's our contact information if anyone has any questions later on, and we have no relevant disclosures. So I kind of wanted to start off with an overview of rare bleeding disorders. I'm sure all of you are aware that this is really a group of disorders that include both deficiencies of coagulation factors and platelet disorders. And the clinical symptoms among those with rare bleeding disorders really vary significantly between disorders as well as patients, even those who are affected by the exact same disorder. And so I think women with rare bleeding disorders require very specific attention and special care. In addition to the common bleeding symptoms, they may also experience a lot of gynecological symptoms, such as heavy menstrual bleeding, spontaneous abortions with pregnancy, increased bleeding during vaginal delivery. And all of these have reported in about 20% of women with all of these deficiencies. And specifically, pregnancy and childbirth really pose particular clinical challenges for patients and clinicians alike, and really complications during pregnancy and the postpartum period have been frequently reported. And so these are events that I think should really be focused on because they can both impact quality of life and employment moving forward. So the evaluation of worldwide rare bleeding disorder distribution involving factor deficiencies really relies on two large surveys that collected epidemiologic data. One specifically is led by the World Federation of Hemophilia, and the other is a European Network of Rare Bleeding Disorders. And so the data from both surveys confirm that factor 7 and factor 11 are the most prevalent, representing about 37 and 26% of the rare bleeding disorder group respectively, followed by deficiencies in fibrinogen, factor 5, factor 10, factor 13, and both combined factor 5 and factor 8 deficiencies. And then the rarest disorder being factor 2, with a prevalence of about 1%. They also revealed that half of the available data really originated out of Europe, underscoring the need for increased efforts to establish accurate diagnosis and improve worldwide data collection systems. So here's just kind of a table for all of you to review, and just gives a general overview of the features of rare bleeding disorders that we'll discuss today. It displays the deficiencies and or dysfunctional proteins, the estimated prevalence in those initial deficiencies, and then some baseline laboratory investigations that can help lead to the particular diagnoses. So, however, since there are so many, I did want to focus on about 5 specific ones today. So the ones listed in red will be the one we'll focus on the most. So fibrinogen deficiencies, factor 7 deficiencies, factor 10 deficiencies, Glanzmann's thrombasthenia, and also platelet storage pool disorders. So here's kind of a schematic that we use, and it shows how us as hematologists really approach someone who's presenting with either signs, symptoms, or a significant family history. That kind of clues us in or makes us think about a bleeding disorder who require a workup. So once there's noted to be an abnormal clinical evaluation, we first start with routine coagulation testing. This includes specific tests like your prothrombin time, your PTT, fibrinogen levels, and von Willebrand testing. If any of these tests are abnormal, then we'll start considering diagnosis of von Willebrand's disease, blood clotting defects, or potentially a fibrinogen disorder. If these tests are normal, we would then consider potential platelet function disorder. Additionally, as part of routine testing, we also perform a complete blood count, review the blood under the microscope, and this oftentimes can give us a little bit of information as well. If the platelets are low but present, we can evaluate this under the microscope, specifically looking at different sizes, the granulation of the platelets, and if the platelets are normal or low in number, this would prompt us to do additional platelet function studies as noted above. Furthermore, if there's any known family history with a known genetic finding, next genetic sequencing will also be performed and is kind of becoming more of the mainstay in treatment and diagnosis today. So due to the low prevalence of rare bleeding disorders, current knowledge on the genetic, laboratory, and clinical findings really remains limited. So scientific reports are usually limited because there's only they're only able to study small groups of patients, or sometimes are only even single cases that they are reporting on. So evidence-based data and guidelines for diagnosis and management of this particular patient population is definitely lacking, and something that as we continue advocating or working towards improving. Specifically, the European Network for Treatment Centers, entitled the European Network of Rare Bleeding Disorders, which was established back in 2007, really was designed to report clinical and laboratory, including phenotypic studies and genetics testing, and kind of gather therapeutic information. And so in 2012, they published the first report that explored the relationship between coagulation factor activity levels and clinical bleeding experience. And just showed that usually, in that majority of the time, that these are not uniform, and your level is not always associated with a deficiency factor in your clinical symptoms. So in this study, the strongest association between clinical bleeding severity and coagulation factor activity levels were seen in fibrinogen deficiencies, factor 10 and factor 13 deficiencies, whereas patients with low coagulant activity levels had a higher occurrence of spontaneous or major bleedings, while patients with sufficient activities remained asymptomatic. However, with patients with factor 5 or factor 7 deficiencies, really did show a poor association between your coagulant activity level and bleeding severity, whereas factor 11 deficiency showed no association at all. So this just kind of showed us that there's still a lot more to learn about these areas, and specifically these rare bleeding disorders, and how to classify them and determine the risk of bleeding. And as we go through each presentation that we'll talk about today, will really, I think the take-home message is that a lot of what we do is very patient-specific and individualized. So now I just kind of want to discuss a list of medications that can affect your platelet function, which in turn can increase your bleeding symptoms, whether you have a coagulation deficiency or a platelet function deficiency. However, I think it's important that each patient should really review all of your medications with your hematologist to really weigh the risks and benefits of each medication. And oftentimes when medications are added that are needed, we can continue them, and as long as we manage bleeding symptoms in other ways. For example, we have patients with bleeding disorders who either require SSRIs for anxiety or depression symptoms, but may now be having increased heavy menstrual bleeding. So the bleeding symptoms can be managed with an antifibrinolytic agent such as Lysetta or Amicar, and she can continue her SSRI because this is important for improving quality of life. Therefore, like I said, if you're requiring any medications that may affect or increase your bleeding symptoms, it really is important to discuss with your physician, and a really individualized plan can be developed based on your own goals and symptoms. Additionally, I think it's really important to discuss all vitamins and supplementations you're taking, or before you start taking with your doctor, really just to ensure that they're not increasing your risk for bleeding symptoms as well. So this is just kind of a chart for your guys' review that I'm sure you have gone over with your hematologist. Additionally, here's a list of all natural products that can affect your platelet function. This information really has come from studies that has tried to look at benefits of natural food products in decreasing risk of thrombosis, specifically those in cardiovascular diseases, and really have not been studied specifically in those with bleeding disorders. But it did show us that certain foods and or their bioactive components have really been shown to be effective in decreasing platelet activity through a variety of mechanisms, suggesting that there are benefits and can definitely attenuate the future risk of thrombosis. But as I said, in a patient with bleeding disorders, this may be a problem. But there really is no studies. So if you're consuming any of these products and it results in worsening bleeding, we're not saying you need to stop taking these or eating these foods, but definitely talk to your doctor about these types of supplementations and see if they have any concerns. So now that we kind of have an overview of rare bleeding disorders, which we know are made which disorders make up this group and how bleeding disorders are worked up. We will discuss really different kind of case scenarios that may be either relevant to you or someone you know as we talk about each bleeding disorder moving forward. So our very first case, we have a 7-year-old boy with recurrent nosebleeds and easy bruising. He has a history of moderate bruising with vaccines in the past, and mom has also occasionally noticed bruises the size of a quarter on his arms and legs. His nosebleeds have been much worse over the past month, which prompted mom to take him in to be evaluated, and he has never had any surgeries in the past. So his pediatrician obtained some basic lab work, and he was found to have a low hemoglobin at 10, signifying he's been losing blood. And his ferritin is also low at 3, signifying that this probably has been going on for a while, and his iron stores are now low and depleted. Platelets, as well as coagulation studies, including his PT and PTT, which we know are tests that measure the time it takes our bloods to clot, are both prolonged for his age. So after this, we got a fibrinogen level, which were obtained and found to be low. So this new finding, in conjunction with the prolonged coagulation factors, really is consistent with a fibrinogen disorder.
Recording in progress.
Oops.
Hi.
I'll throw you back into your room.
Thank you.
So just kind of an overview of the primary function of fibrinogen, it really is it is the formation of fibrin and blood clots. And so fibrinogen has other functions as well, as you can see by this kind of flow diagram here. Other varied functions of fibrinogen include the breakdown of a clot, also known as fibrinolysis. It plays an important role in inflammation and in maintaining balance between formation of blood clots to prevent bleeding and the breakdown of blood clots in the body to prevent clot formation. And so fibrinogen really can be measured in 2 ways. The first way it can be measured is in the activity, or how well the fibrinogen that you have works, or if you can measure the antigen, and this really just is the amount or number of fibrinogen that you have present. So when we talk about fibrinogen disorders, sometimes this is also classified as a factor 1 deficiency, but really is an umbrella term for several related disorders known as congenital fibrinogen defects. So one of them, there's many that we'll talk about. So you can have afibrinogenemia. These are all a mouthful, and it's a complete lack of fibrin. You can also have hypofibrinogenemia, where you have low levels of fibrinogen. And this is specific, both of these are quantitative defects, meaning the amount of fibrinogen in the blood is low. You can also have dysfibrinogenemia, which is more of a qualitative defect in which the fibrinogen is there, but it doesn't really work in the way that it should. Or you can have something called hypodysfibrinogenemia, which is a common defect that involves both low levels of fibrinogen and impaired function. So going back to our case, the little boy with the nosebleeds, it's likely that this patient's symptoms and lab findings are more consistent with a dysfibrinogenemia. This is a disorder where the structure of the fibrinogen is defective in itself. And so this faulty structure stops the conversion of fibrinogen into its active form, fibrin. And as a result, all the function of fibrinogen, as we discussed in a previous slide, is affected. So individuals with fibrinogen disorders really can have bleeding or thrombosis, so bleeding or clotting symptoms. The bleeding is due to dysfibrinogens resulting in loss of proper clot-forming structures. And then the risk of thrombosis or clot is due to the dysfibrinogen resisting fibrinolysis, which is what helps you break down the clots. So it really has a factor and a role in both, which is why you can have bleeding or clotting symptoms. So bleedings in patients with fibrinogen disorders really vary. You can have greater bleeding risks in those who have afibrinogenemia or lower levels of functional fibrinogen. And then the age of onset is also extremely variable, with earlier onset in those with more severe deficiencies or functional impairment. So there's been various case series that have been reported that majority of individuals may not present with bleeding at all, may be asymptomatic. And in fact, over half of the individuals in various series who've been diagnosed have been asymptomatic and identified as either an incidental finding or through familial screening. And most bleeding manifestations are mild, but some can be severe. And the most common bleeding manifestations are heavy menstrual bleeding in women, followed by more cutaneous bleeding, such as like nose bleeding, gum bleeding, post-operative bleeding after surgeries, or GI and internal bleeding. So the majority of individuals with congenital dysfibrinogenemias do not really develop clots, although there is an increased risk compared to others, and it's about approximately 20 to 30% that may have a thrombotic event at some point in their life. Additionally, as we kind of discussed earlier, pregnancy really is a high-risk clinical situation in women who have fibrinogen disorders. Miscarriages and pregnancy complications, including postpartum hemorrhages and thrombosis, have all been reported, although most pregnancies do progress smoothly. These are just things that we need to kind of think about. All right. Oops. All right, so when we want to go and evaluate a patient for suspected fibrinogen disorder, this is just a really good algorithm that can kind of break down the differences if that's something that you're interested in. So an abnormality of fibrinogen may be suspected, again, like in our patient, if there's a prolonged PT or prothrombin time, prolonged activated partial thromboplastin time, or APTT, or a prolonged thrombin time, which is a TT, as seen in our case. And usually, as a general rule, your thrombin time and your prothrombin time are more sensitive than just the PTT. And then when we talk about treatment for fibrinogen disorders, the conventional treatment is usually on demand with fibrinogen concentrate, but effective long-term secondary prophylaxis with fibrinogen concentrate administered anywhere between 7 to 14 days has also been described for those who have fibrinogenemic patients who have had some sort of recurrent life-threatening bleed, such as bleeding in the brain or undergoing surgery. Additionally, fresh frozen plasma or cryoprecipitate may also be used as a replacement or given prophylactically. However, really the decision on which to use is very patient specific, and it is dependent on each patient's specific clinical symptoms. So again, as we talked about, treatment for some of these really is individualized for the patient and really depends on what your particular bleeding phenotype may be. Additionally, as we talked about, high level replacement during high risk times, which one of those would be pregnancies, should be considered and discussed mainly by a multidisciplinary team. Preconception counseling should be provided adequate information on the clinical and genetic implications of pregnancy, and then routine use of replacement therapy during pregnancy in pregnant women without prior history of bleeding or thrombosis may not be indicated, but again, kind of determined by your multidisciplinary team on an individual basis. Additionally, there can also be discussion for prophylactic heparin or low molecular weight heparin use in the postpartum period if anyone has a more thrombotic phenotype as well. Okay, so now we're going to move on to the next case. I'm just going to check the chat. Okay, we will get to them at the conclusion of the presentation. Okay, so next, our case that we're going to talk about is an 18-year-old young woman. So she's referred to hematology because of heavy menstrual bleeding. She started having periods at the age of 13 and since has really missed 1 day of school each month because of her periods. They last about 8 days and she needs to use Super Plus tampons, which she has to change every 1 to 2 hours on her heaviest days. She has never had any surgeries in the past. However, her mother also had a history of heavy menstrual bleeding and also postpartum hemorrhage requiring blood transfusions. Workup is consistent with anemia, a normal PTT, and a significantly prolonged PT, which was suggestive of a diagnosis of factor VII deficiency. Therefore, factor VII activity levels were obtained and noticed to be low, confirming the diagnosis of factor VII. So I just want to talk about the role of factor VII a little bit. This is a coagulation factor that is a part of the extrinsic part of the coagulation cascade. It ultimately helps in clot formation. And factor 7 is specifically dependent on vitamin K for its function and is made in the liver. Additionally, factor 7 levels are affected by many things, such as sex, age, your cholesterol level, and triglyceride levels. So there are many things outside of just your genetics that can affect this level. Additionally, factor 7 deficiency is the most common autosomal recessive inherited coagulation disorder, where we see this in about 1 in 500,000. And it is commonly divided into two groups. So there are type 1, which we would consider a quantitative defect with both a decreased factor 7 activity and a low factor 7 antigen. And then type 2, which is more of a qualitative defect where you have a low factor 7 activity and your factor 7 antigen levels are really either normal or near normal. Additionally, there is a type of one specific genetic mutation, factor 7 PADA. This is a special variant of factor 7 deficiency. It has a very low prevalence, but a worldwide distribution, which is why I thought it'd be important to discuss. It's characterized by different reactivity towards different tissue thromboplastins. And so this is just the way when we test the levels in the lab, and is really an example of type 2 variants, as an antigen levels are always normal. And this will kind of come up in a couple different slides later on. So factor 7 deficiency presentation is extremely variable between patients and oftentimes is not directly correlated with the patient's factor 7 activity levels, as we talked about earlier. Interestingly enough, it's McBell et al. Has noticed that a complete absence of factor 7 in the plasma is usually incompatible with life, and individuals may die shortly after birth due to severe hemorrhages. Some patients do not bleed despite a very low factor 7 activity, although, whereas others with similar levels may experience frequent bleeds. The minimum level of factor 7 needed to avoid bleeding in different clinical situations isn't truly known. Some authors state that maybe a factor 7 level above 8 could be associated with extremely low risks of severe bleeding during surgeries, and others report that a level of about 15 to 20% is generally sufficient. But overall, I think the general consensus is that a factor 7 level should be over 20% to control bleeding and to ensure safety during surgeries. And so I think that's what most of us try to aim towards when prior to surgical procedures. And this is because they think that the combined enhanced effect of both factor 7 and tissue factor complex work together to trigger effective coagulation, even with the low levels of factor 7. However, we do know with the variability that this may not be true for each patient. So those who do have bleeding symptoms, the most frequent are epistaxis or nosebleeds, easy bruising, heavy menstrual bleeding, and then sometimes can be as severe as life or limb threatening, although those are more rare. And in these reports, their CNS or brain hemorrhages have been reported in an incident of 7% of patients, and interestingly enough, 5% of females. Additionally, thrombotic events such as deep vein thrombosis and pulmonary embolisms have also been reported in about 3 to 4% of patients with factor 7 deficiency. Venous thrombosis or clots are more frequent in factor 7 deficiency than arterial thromboses. And the reasons for that really are unclear. Additionally, those known with the specific factor 7 PADA mutation really have been known to have a higher than expected incidence of thrombotic events. So these patients, because of their frequent lack of bleeding and their relatively high prevalence of thrombosis, require different types of treatment and care when compared to other patients with factor 7 deficiency, and should receive very limited replacement therapy in the cases of surgical procedures for that reason. So when we talk about treatment for factor 7 deficiency, this is a little bit hard due to the significant variability in clinical manifestations and symptoms. As we know, they don't really correlate well with the plasma factor 7 levels. So the management during surgery or for long-term prophylaxis really does remain challenging and needs to be individualized and patient-specific. Various therapeutic options are available for factor VII deficiency. However, plasma-derived factor VII concentrates and recombinant factor VII concentrates are really considered the optimal replacement therapy used at low doses. Prophylaxis has been debated in factor VII deficiency, but has been used in those who have had severe bleeds. And then the infused factor VII concentrates have a very short half-life, which also contributes to the difficulty in establishing standardized prophylactic protocols for these patients. So lots of things that make treatment difficult, but also just knowing that it is very patient-specific and really relies on each patient's bleeding phenotype or clotting phenotype if they have particular mutations is important, and things that definitely need to be taken into consideration on an individual basis when someone is considering treatment. Now, during pregnancy, special considerations are needed for those with factor VII deficiency. Delivery method is determined based on both maternal and infant conditions, as well as obstetric factors. And some patients, depending on the mode of delivery, their specific bleeding tendency and factor VII activity levels may require factor VII concentrates, and others may require no treatment at all, but will definitely undergo close monitoring, as you can see per this algorithm. Okay, I'm just gonna take a quick. So that brings us to our next case. So this third case is a woman who gives birth to a beautiful baby boy, although her delivery course was complicated with prolonged postpartum hemorrhage that was difficult to control. Hematology was consulted for help in management of her postpartum hemorrhage, and a discussion on workup to determine the cause of her prolonged bleeding after delivery was had. So initial lab work included a low hemoglobin consistent with her acute blood loss and a prolonged both PTT and PT. And so due to both of these coagulation factors being prolonged, there was a concern for a factor deficiency that may affect both pathways of the coagulation cascade. And ultimately, a factor X activity level was performed, which was found to be low, confirming the diagnosis of a factor X deficiency. Genetic testing was then performed, showing that the patient has a heterozygous, so where she only has one mutation in her factor X. So kind of going back to the overall role of factor X, factor X is a coagulation factor that is a part of what we would call the common pathway of the coagulation cascade, and it's both where the intrinsic and extrinsic pathways kind of come together. And I really like to think of it as X marks the spot, and they come together at that exact point. And so that's why both the PT and PTs are prolonged in these patients. Factor X ultimately helps lead to clot formation and is really a key clotting enzyme protein that helps form what we call a stable clot and reduce bleeding in patients. And factor X also is vitamin K dependent and is made in the liver, just like factor VII. Factor X deficiency is inherited in a similar fashion as factor VII. It is autosomal recessive, where you need to get one gene from each parent. However, it is known that patients who were once considered carriers because they only had one affected gene, also known as heterozygosity, can still have bleeding symptoms after trauma or surgery, as we saw in our patient case. So in factor X deficiency, the bleeding tendency can appear really at any age, although the more severely affected, so those who have less than 1% of factor X, present earlier in life, initially can present with umbilical stump bleeding, bleeding in the brain, bleeding in the stomach or intestines, and patients with severe deficiencies commonly experience bleeding into the joints and significant bruising as well. Common symptoms reported at all severity levels include nosebleeds and heavy menstrual bleeding. And then additionally, as we talked about, if you have a heterozygous patient, or a patient who only has one affected gene, as seen as our case, there have been reports with postpartum bleeding requiring treatment. So when we talk about treatment for factor X deficiency, we do have data from the United Kingdom Hemophilia Center registry that demonstrates that a proportion of factor X deficiency patients requiring treatment is much higher than those with other rare bleeding disorders. Therapies usually administration of factor 10 concentrate to try and maintain and recommend an activity level of about greater than 40%. When this isn't available, we can also use prothrombin complex concentrate or fresh frozen plasma. Therapeutic options for control of menorrhagia include antifibrinolytics such as Amicar, Listida, hormonal suppressive therapy, IUDs, and clotting factor replacement can also be considered. Prophylactic plasma complex concentrate or factor 10 concentrates can also be used in those with recurrent life-threatening bleeds or those who are undergoing surgery. And then even if factor 10 plasma concentration is increased in pregnancy, women with severe deficiencies and a history of adverse pregnancy outcomes may benefit from continuous replacement therapy during pregnancy as well. Okay, so our next case that we're going to talk about is a 12-year-old girl. She presented with significant bleeding when she brushes her teeth. She was recently seen by her dentist for routine cleaning, who noted more than normal gum bleeding during her visit and referred her back to her doctor. Upon questioning, it was also discovered that she had continued easy bruising. So her doctor obtained some lab work that was consistent with the low hemoglobin of 10, a low ferritin, again signifying blood loss over a long period of time, resulting in depletion of iron stores, and a normal platelet count and normal coagulation levels. So therefore, von Willebrand factor levels were obtained and were also noted to be normal. So a patient with mucocutaneous bleeding, so gum bleeding or nose bleeding with normal von Willebrand activity level, we really need to think about another type of platelet disorder. And then we also want to look at the platelet number. So here we saw that her platelet numbers were normal. So now we need to think about, okay, are they functioning properly? And therefore, a platelet aggregation was performed in this particular patient and showed that there was an absent aggregation or absent clotting with all agonists except one, suggesting a diagnosis of Glanzmann's thrombasthenia. So the diagnosis was then confirmed by flow cytometry, and this really looks at the different types of markers on the cell surface of the platelets, and they're looking for expression of a particular glycoprotein, and if it's not there, then this confirms a diagnosis of Glanzmann's. So this is also inherited in an autosomal recessive fashion, just like the last two rare bleeding disorders we discussed, and results in a functional deficiency of a very important receptor that's found on the cell surface of platelets. It's called a GP2B3A receptor, which is another mouthful. But this receptor is really important and aids in platelet aggregation or really sticking together of the platelets to form that initial platelet plug when injury occurs to a vessel. This platelet plug is also formed with the help of fibrinogen, as you can see in this image. And most of these patients will have normal platelet counts, and their platelets will also look normal under the microscope. So to diagnose Glanzmann, there are two tests to confirm the diagnosis. These include platelet aggregation testing, also known as a light transmission aggregometry. And this test really, the way it works is it measures the amount of light that can make it through the sample. And as the sample starts clotting or aggregating together more, there is less light that is shown through. And then the second test that you can do is genetic studies. Additionally, evaluation by flow cytometry, as we talked about in the case, can be used to really classify different subtypes of Glanzmann's and evaluate for the risk of antibody formation, which we'll talk about a little bit more later. So Glanzmann's is divided into three subtypes. The first type is where you have less than 5% of the glycoprotein that's found on the cell surface of the platelets. This results in both absent or severely deficient fibrinogen binding and absent clot retraction. Type 2 is where you have 10 to 20% of the glycoprotein found. You do have the presence of fibrinogen binding, and you have normal or moderately deficient clot retraction. And then the third subtype is considered a variant. So this occurs when there is greater than 50% of the glycoprotein found. However, patients still have variability in both fibrinogen binding and clot retraction, which leads to just a variety of symptoms. So when we talk about the symptoms of Glanzmann thrombasthenia, they really vary quite a bit from one individual to the next, from very mild to potentially life-threatening bleeding. Glanzmann's often causes more problems for women than men because of menstruation and childbirth. And signs of disorders are usually first noticed during childhood. And so those with Glanzmann's may experience easy bruising, nosebleeds, bleeding from the gums, heavy or prolonged menstrual bleedings, or bleeding after childbirth, abnormal bleeding after surgery, circumcision, or dental work, but rarely you may have vomiting or passing of blood in the urine or stool due to bleeding in the gut. So most of those people with platelet dysfunction disorders only need treatment during surgical procedures requiring dental work or after injury or accidents. So when needed, Glanzmann's may be treated with an antifibrinolytic drug. A single antifibrinolytic agent can be used as monotherapy if there's mild bleeding, or in moderate to severe bleeding, a single agent can be used in combination with other hemostatic agents such as recombinant factor 7. You can also potentially use fibrin sealants, hormonal contraceptives to control excessive menstrual bleeding, iron replacement if need to treat anemia due to this excessive prolonged bleeding, as we saw in our case, or platelet transfusions if the bleeding is severe. And then additionally, those with inherited platelet function disorder should really not be taking aspirin, NSAIDs such as ibuprofen or naproxen, or types of blood thinners, which can make their bleeding symptoms worse. And then as we talked about, we know that pregnancy is a high risk period for many with bleeding disorders, specifically for patients and women with Glanzmann's, and a multidisciplinary plan of management really needs to be established with hematology, obstetrics, and anesthesia, all three, when pregnancy is confirmed, to plan for antenatal management, delivery, and prevention of postpartum hemorrhage. So pregnancy really should be closely monitored for any sort of antibody formation. Mothers may already have or may develop antibodies to platelet glycoproteins, and these antibodies can cross through the placenta to the baby and cause severe bleeding in the baby, which is why it's so important to be monitored closely, because this can put baby at high risks for bleeds, specifically in the brain, is what we're most concerned about. Therefore, it's important to ensure that the mother is appropriately screened for antibodies, and if they are present, appropriate treatment should be considered, such as steroids or something that's called IV immunoglobulins. Additionally, epidural analgesics is categorically contraindicated because of the risk of bleeding and paralysis. And so pain should really be managed with other options for Glanzmann's patients. Instrument delivery should be avoided due to the risk of neonatal low platelets and concern for bleeding in the baby. Then it's really important to develop a plan like this for each and individual patient. Should be done by a multidisciplinary team to ensure safe, successful deliveries. Okay, so then our next and last case, we will talk about a very cute boy who has a toothache. So he has no previous surgeries. He's been having a persistent toothache for which his mother took him to the dentist and has found a cavity that needs to be removed. During the extraction, he had more bleeding than usual that required an emergency department visit. So in the ER, he was noted to have a mild anemia due to the blood loss with the procedure, but the rest of his initial coagulation screening was normal, including both his PT, PTT, as well as platelet count. The bleeding was controlled in the ER, and the patient was referred to hematology as an outpatient. So he went home, followed up with hematology afterwards. So upon evaluation in the hematologist's office, it was noted that the patient has had a significant history for easy bruising and nosebleeds. And when his blood was looked at under the microscope, it was found to have abnormal looking platelets that had decreased granulation normally or uniformly throughout the sample, thus suggesting potentially a storage pool disorder. So platelet storage pool deficiencies really refer to a group of conditions that are caused by problems with the platelet granules. Platelet granules are these tiny storage sacs that are found within the platelets, and they release various substances to help stop bleeding. So platelet storage pool deficiencies occur when you have platelet granules that are either absent, reduced in number, or unable to actually empty their contents into the bloodstream. So there are two types of granules, and they make up part of the two different some of the different types of platelet storage pool diseases. The first are alpha granules, and the second are dense granules. So some storage pool deficiencies are caused by lack of granules, but the most common ones are caused by a failure of the platelets to empty the contents of the granules into the bloodstream, as we talked about. And these specifically are called secretory or release mechanisms, which are inhibited. So the diagnosis of storage pool deficiencies really require a careful medical history and a series of tests. And so in people with storage pool deficiencies, you can see the platelets that don't clump together in the way they should in the special laboratory test known as a platelet aggregation. So that will be abnormal. And then the granules may not be visible when platelets are looked at under the microscope. So this is an example in this image so figure B on the right with all the dark spots are the granulations compared to the image on the left, which is figure A, where you see no granulation. So this is really absent granulation here in the platelet. So symptoms of storage pool deficiencies really vary from one individual to the next, but they're usually either mild to moderate. People with storage pool deficiencies can experience easy bruising, nosebleeds, gum bleeding, heavier prolonged menstrual bleeding, or bleeding after childbirth, and abnormal bleeding after surgery, circumcision, or dental work, as we saw in our case. The clinical presentation is sometimes unclear, and the diagnosis and management of bleeding risk in these patients really does remain complex, mainly in those with non-syndromic forms of this disease. And because the diagnosis really relies on the use of specialized techniques such as electron microscopy and collaboration between physicians, routine hemostasis clinical labs and research labs are recommended, as well as specifically doing genetic testing, which would be the final step of an accurate diagnosis for these patients. In most people with storage pool deficiencies, they only need treatment during surgical procedures, including dental work or after injury or trauma. So in the case of surgery, prophylactic platelet transfusions are not recommended for patients with storage pool disorders. And prophylactic and post-operative treatment using tranexamic acid, an antifibrinolytic agent, and desmopressin, should be preferred as long as the bleeding risk is limited. However, it's important to know that desmopressin may not be the most useful in those who have alpha granule deficiencies. So because platelet transfusions are not mandatory to manage moderate bleeding for those patients, and because it may lead to platelet refractoriness, platelet transfusions should really be reserved for any sort of massive bleeding events and for bleeding that is not controlled by classical therapy. Activated recombinant human factor 7 can also help stop massive bleeding in most cases, and we kind of consider these to kind of go around the platelet dysfunction, platelet issue, and kind of focus more on the clotting cascade. And those individuals with inherited platelet function disorders, again, really should not be taking aspirin, NSAIDs, or any sort of blood thinners, which may worsen their bleeding symptoms. Okay, so that actually wrapped up our 5 cases that hopefully will kind of help you remember the different things about each of these 5 rare bleeding disorders that we talked about. And next, I just wanted to spend a few slides kind of talking about the different resources and the advocacy that's kind of going on in the rare bleeding disorder community. I'm sure as many of you are aware, there are numerous organizations that focus on both educational resources for providers and patients, as well as advocacy for patients with rare bleeding disorders. As all of you are part of the Ladybug program, we know this focuses on women's health and patients with my personally favorite word, hemophilia, and other rare bleeding disorders. So I think this is great work, and there are a lot of amazing programs out there that are doing similar things and really making a big impact on different levels. So there are other institutions such as the World Federation of Hemophilia. They have e-learning resources for both patients and providers alike to help improve our understanding and knowledge of patients with rare bleeding disorders and how to best care for them. The National Organization of Rare Diseases has focuses on advocating for research specifically in the field of rare bleeding diseases. And the Hemophilia Foundation of America has advocated at the congressional level to help amplify the voices of bleeding disorder, all the voices of the bleeding disorder community, and to help improve access to quality and affordable care, which I think is amazing. Additionally, then the National Hemophilia Foundation has been working to improve access to healthcare for the entire bleeding disorder community, as well as offer several opportunities for you to meet with your chapter organizers and to speak with your legislators about really what's important to you. And so that can kind of be taken to the next level. So I just wanted to thank everyone for listening and attending today, and really just kind of open up the floor if there's any questions or discussion from this point forward.
And indeed, there are questions. So let's see, we'll go back to the first one that started. And they're great questions. And thank you so much, Dr. Valenti, for sharing your knowledge. Okay, let me get to the first one. We have several questions about eye hemorrhages in individuals with factor VII deficiency, and also the parent of a child with of a daughter with factor VII deficiency, who also is affected with factor V deficiency. So I just want to make certain I get this all phrased correctly. What is the recommended treatment for constant subjunctiva hemorrhages of the eyes? And I want to also get to that other question. Somebody else has had them for over 20 years prior to diagnosis, uses Novo-7 prophylactically, so that has made a huge difference in the number of hemorrhages that she's had. And again, the father of a young lady who also gets these hemorrhages about once a year, and he has a reduced factor V level. 7 level.
That's a great question. And I think just in general, what's fascinating about factor VII deficiency is that it is extremely variable. And I try to convey that. And I'm sure as anyone who has factor VII and who's talked to anyone else, you know, everyone's kind of symptoms and pictures look so different. I would say that retinal hemorrhages are definitely not the most common. They are things that I have seen. And I would agree. I think if it's something that has continued and is recurrent, then that would be a reason for prophylactic treatment. Most commonly would be with like a factor VII concentrate, such as Novo-7 or something along the lines of that. I think that it really depends on the severity of the bleeding and how frequently it's happening. If it's secondary to trauma, maybe a treatment in that instance is appropriate. And if it never happens again, then I may not prophylactically treat. But if it's something that's recurring, I definitely would potentially start that patient on prophylaxis and just see if that actually does help. And especially if it is something that is affecting vision or anything else causing other problems, then that would be something that should definitely be investigated and discussed with the hematologist on what's best to do moving forward. So I hope that if that didn't answer your question, let me know.
Yeah, please. If you have follow-up questions to this, feel free to unmute.
Absolutely.
And I mean, that's the reason why we had this Q&A session.
Yes, Dr. Gianni, thank you so much for a wonderful presentation. I have factor VII, and I do suffer with these continuous eye hemorrhages, but I also want to note that maybe somewhere it can start being documented that this is a presentation symptom of folk with factor VII. No, not all of us may have it, but there's enough of us seem like reporting here that this is a symptom of factor VII patients.
No, absolutely. And I have, and I've also seen that. And I think that, I was actually going back and it doesn't seem like that has been reported as a more common symptom, but I think that that is an important thing to bring up. And I think very unique, and also what makes factor 7 deficiency so complex. Like I said, just the variability in presentation. And I think especially if you're having recurrent bleeding with no trauma, if you didn't do anything and you're now bleeding in your eye, there's no reason for that. So definitely should warrant workup. I agree. And I'm going to probably look back at my own patient subset and see if there's anecdotally anything I find on that being a common presenting symptom.
Thank you so much. And this is why this is so important for us to be able to continue to get together as patients with rare bleeding disorders, because you guys teach us so much.
Absolutely.
It's amazing. We have another question. I have a 15-year-old daughter who has had many more bleeding issues the past few months, heavier periods, multiple hematomas, significant bruising. Can factor 7 vary over time? What would cause this? She has factor 5 and 7 deficiency, heterozygous for factor 7, and unknown etiology for factor 5.
So that's another great question. And I think there was a slide that we talked about how there are a lot of things that affect factor 7. I think I may have talked about it on this slide. So age, so yes, cholesterol, sex, triglyceride, all of those things can affect it. And so I think because she has 2 bleeding disorders, so it's kind of unclear on which would be the most contributing factor to her bleeding symptoms. I think that's just a little bit hard for me not seeing kind of her lab work and where her levels are. But as we know, that may not actually tell us the most about what her particular symptoms will look like. I think this definitely is a good question to prompt her hematologist to see should we be doing something more, like, because this is happening, should we be on, if we're not on prophylaxis, should we be on prophylaxis? What can we do to control her menstrual periods? Because I feel like there's so many options, at least for that, then that's definitely something they should be able to take care of. And if you are on prophylaxis, is there something different we need to be doing it? Or maybe because there is kind of this dual factor 5 and factor 7, should we be approaching this maybe in a different way? Could be a good question to ask her hematologist. And I do sometimes see, especially in, I think a lot of the conversation and topics that we talked about today is like for women specifically, once they're having periods, once they're ready for pregnancy and delivery, those are when we do see a good chunk of complications that kind of happen. So I think special attention to those areas are extremely, extremely important.
Thank you. Does that answer your question, Lydia? Where'd she go?
Yeah, thank you, that does.
Okay. And it's so hard.
Yes.
Yes, absolutely. We have another question. My 10-year-old daughter with GT had a dental procedure done January 9th. She lost a lot of blood and needed platelets and iron transfusions. Oh, Nancy, I'm so sorry. January 31st, she tested positive for COVID with no other symptoms besides passing out, headaches, and dizziness. Since then, she's passed out about 6 times and is constantly having headaches, stomach aches, dizziness, fatigue, and weakness in her legs. Her hemoglobin is 11.4 and she's not bleeding. So hematology is saying to follow up with her pediatrician. After many ER visits and multiple other appointments, all I get is to hydrate her and give her sodium tablets. They keep saying it's normal. But mom has a really big concern that she's passing out and she's afraid she's going to get hurt with her platelet disorder. And we're now on to the GT question. So I've got another one here too after this one.
Okay. I will go over to those slides. Not that I don't think I have a slide that helps answer this question. I understand the concern because I agree. I think anyone with a bleeding disorder, I don't want them falling ever. And so that is definitely concerning. I think a few things. I think it's important to kind of think about, and her hematologist may have a good understanding of where her hemoglobin was, because even 11 is, not perfect for probably if she's a teenager, but are there any other like vital sign abnormalities? And if they did follow up with the pediatrician, maybe a cardiology evaluation may be something worth asking for, just because it is common in teenage girls, I think, to have some sort of to have symptoms like this when they are not having enough salt in their diet, which is why they had her start the salt tablets and things like that. I just think that with a patient who has a bleeding disorder, I think that we can't necessarily treat it the same way as I would a teenager who, if they're falling, I'm not as concerned. I think if a patient with Glanzmann's is going to pass out and potentially hit their head or what, anything, really just anything, that's extremely concerning. And so I think just maybe that could be a good potential question to see if cardiology follow up.
Sorry to interrupt.
No,
Yeah.
please.
No, she already saw cardiology. And
Okay.
that's the cardiologist is the one that told me to give her sodium tablets and more hydrate her more. He also said if you feel like you're gonna pass out, just lay on the floor.
I mean,
That's
that is,
Yeah.
He really didn't do any testing. She had already had an EKG done, which came back normal.
Mhm.
But just, I don't know, but I just feel
Yeah.
like lay on the floor and raise your legs up whenever you feel like you're gonna pass out, and she's having these symptoms all day long is just not the answer
Right.
that I was looking for when I went to see him.
I will say that I think most teenagers who have similar symptoms, that is usually the types of things, and then they do outgrow it. However, I think in a patient with any sort of bleeding disorder, it does make me a little bit more nervous as a hematologist. I agree. I think their recommendations, more water for sure, more salt, those things may help. And if those things are not helping, then I think being persistent, I think, is always important. If you obviously as a mom, your daughter best, and knowing that there needs to be something else that is done I just want you to continue to be persistent, because I think that that's the most important. I don't personally have any additional recommendations. I agree with what they said, but I feel like, could there be anything else so we can prevent this from happening and causing further issues, if that makes any sense?
There was a comment in this thread about there seems to be one mom had shared that there seems to be more individuals who are having symptoms of POTS after having COVID. Have you heard anything like that, Dr. Valenti?
I have not seen that specifically, but I have not had I think the patient population I take care of, we have protected pretty good from COVID, just because I do oncology as well. And so I think people have been very, very good about that. And, not seeing general pediatric patients anymore. I'm not familiar with that particularly, but that's very interesting and could be something worthwhile to see, to look up for sure.
My daughter had POTS. It was a scary journey to diagnosis. And the passing out was really very scary. And she was driving at the time. So feel free to reach out to me anytime, Nancy. I'm happy to just, talk it over with you. And I can say the same thing, for all of us that are mamas in this room. Don't take no for an answer. Lying down just because she feels, she can't necessarily do that in school. That's crazy.
Yes, it's really affected our life for this
Yes.
past month. Me working, her going to school, it's like non-existent currently. And
Mhm.
I'm even afraid to have her do any type of exercise because she's gonna
Yes.
pass out. She's
Yes.
not herself. She's fatigued all the time. She doesn't want to do anything because she's afraid that she'll pass out again.
Mhm.
It's just taking a toll mentally and physically on her and me, obviously.
I get it, honey. I've been there, and just added her daughter has POTS as well. I think we need to start a breakout session just for those of us that had daughters with POTS. Might be helpful. But again, please feel free to reach out. I'm so sorry you all are going through that. I have another GT question. Let me get back to it. I'm trying to find you in our thread here, or if you want to pop on, here it is. I have GT and migraines, and just wondering if you have any concerns for the newer migraine medications like Vyepti, Aimovig, Emgalati, etc., all CGRP inhibitors. And I'm sorry, I mangled some of those names.
No, no, actually it was pretty good. That is a good question. None that I am, not that I like off the top of my head, I'm like, oh, I know that is not, that is contraindicated. I probably would look them up specifically. So I was actually going to look up the, I know Aimovig specifically. So I was going to look that up to see, but I think from my understanding is that should be okay. I think, again, any new medications that you're starting are always good to kind of have a discussion with your hematologist, and so they can at least monitor closely any for, depending on what type of bleeding disorder you have. Are there any new bleeding symptoms? Are you having, if you have a bleeding disorder that puts you at risk for clotting, are there any new things you need to be aware of for those potential risk of increased clots? I don't think these specifically should change that at all. However, I think that depending on each patient's symptoms and just their hematologist being aware is really important. And then that way they can know that that is something that has changed in case there is changes in symptom presentation.
Anything else you want to add?
No, thank you very much for Dr. Valenti. Constipation really seems to be the biggest problem.
The biggest one.
Yeah.
Yeah. As I'm looking quickly, nothing that I'm seeing that is jumping out at me saying you absolutely can't take that. But like I said, a good communication with the hematologist, I think, is important on just new medications and things like that. And hopefully they work well for her, because I know migraines are no fun for anyone.
Thank you very much. Thanks, Janet.
Oh, anytime. You know, I always wish we could find an answer for you.
Me too.
I know.
Thank you.
Any other questions while we have Dr. Valenti? Did you have a question?
Can you hear me?
Yes.
Okay. First of all, I want to say grazie to Dr. Gianna. Thank you so much for this amazing presentation. I would love to dialogue with you further at some other point, but I think what's important to note tonight is that you brought up a lot of situations where there are studies about women or people with rare bleeding disorders. And I like to think of myself as somebody who's on top of everything, but it's like we have so many disparate entities for who is gathering the facts of us and who is doing this in a fashion that actually benefits us. And we really need cohesiveness. And if you can be any part of that, I'd be happy to be part of that, helping you to be part of that. That's all.
Well, thank you. I mean, I really do love interacting, I think, with patients in this community in general. And so I, one, appreciate you guys having me. Two, I think it's important that as I sit here and talk to you, I think presenting data, I think, no one just wants to hear me talk about my opinions, which sometimes are important, but I think factual data is important. And so all of my slides, I really try and focus on really evidence-based data, and all of them you will be able to find the papers that they came from. And so if that's something that interests anyone, or if there's a particular paper or image that you thought was interesting, you can go back, you can pull it up, everything's referenced on the same slides, and just kind of be able to have some understanding. And I feel like what is also super unique about this patient population is everyone is so knowledgeable about these things, more than most people and their medical conditions. And so I think that it's like, very unique a unique community in many ways.
Thank you. That I just want to say that if we could cohesively bond, when I started on this journey, there was the UDC, and then there was the CDC, and then there's Athen, and there's all these different entities that for most of us patients, we never really know or hear about those. And I would love it if somebody of your caliber would help to promote, a rare bleeding disorders registry in the United States. There is one, but it's not really well known. So if you can partake of that, we'd be very grateful.
Yeah, that's definitely something we can discuss. I think would be very worthwhile
to discuss it with you.
Yes, I would love that.
And
Thank you.
That is a good point, Barbie. I mean, one of the things we do know is Athen 10 is, working on making certain that there is that registry, and we can start making certain that we're recording all of your symptoms so that we know more. It's just feels like it's taken forever.
It is. And I want every single person on our little group tonight to know that this is not about factor 7 deficiency. We just happen to be a little bit dominant, okay? It's all about the rares. And you guys who are the ultra rares, ultra rares, haven't really had your chance yet. And I want to continue to fight for that, as I know Janet does.
Absolutely. Knowledge is power. We have one more question that came in, and then we're going to wrap it up. And thank you for, bringing that to light. We're always very cognizant of, our other ultra rare bleeding disorder family. And you're right, because you are such a tiny little group, it feels like it takes even longer for information and studies to come to you. So we'll just keep advocating. But the last question of the night is, do factor 7 levels rise with age for people with factor 7 deficiency?
So that's a great question. So I want to say yes and no, because you are actually born with lower levels. So there's a period where it increases, and then may kind of plateau, and then will increase again. So yes, overall. But the caveat to that is each person's increase looks different. And so sometimes the trajectory won't go up as normal, or if you have a higher level at birth, it may kind of stay there and not go up. It really is variable, but overall there is kind of a general increase over time, with kind of a plateau in, I would say, usually adolescent area before it starts increasing again. So it varies, just like everything with factor 7, I feel like, but the general answer to that is yes.
And I just have to say, as a mom who had 2 boys with severe factor 8 deficiency, I felt like all they did was bleed in adolescence. I don't know what there was about that. I mean, we know adolescence is such a strange period and period of time, and it stands to reason that that they, I guess, as a generalization, that you could expect that they would bleed more, and especially for girls with menstrual bleeding. It's just such a challenge.
And I also think with lots of other factors that affect factor 7, there are different like hormonal changes, and those may be things that we don't actually have like a good understanding of as of yet. But I agree. And I also think, as anyone who's a mom knows, those adolescent years patients are not the most cautious too, which also contributes. There are a lot of factors, I think, in that age range, for sure.
Okay. All right, well, we are at the top of the 9 o'clock Eastern time hour. So with that, again, could we give Dr. Valenti a round of applause?
Thank you so
As we
much.
typically do here. It has truly been
Bravo.
a pleasure. And we will be sending out, just check your email tomorrow. We'll be sending out a survey for this evening's presentation to provide Dr. Valenti with some feedback as she asked for. I know as a presenter, I always love to have that type of information. And with that, thank you, everyone. Love seeing you. We will see you March 23rd, same time.
Thank you.
Take good care, everyone. Good night.
Night.
Bye. Thank you all for having me.